Examination. Oral and throat examination should be done, but the main way to assess dysphagia is to ask the patient to swallow solid food and liquids in front of you. Investigations. We shall start with baseline investigations. Chest X-ray can give us a quick and rough idea about the esophagus, but more importantly, it gives an idea about any aspiration pneumonia. X-ray neck, antero-posterior and lateral view, can give a quick and rough idea about the pharynx, larynx and upper esophagus. If a neck pathology is suspected to cause dysphagia, CT scan or MRI may also be advised. Complete blood count, urea and electrolytes can give an idea about the patient's condition, e.g., does he/she have any electrolyte disturbance due to dehydration. The investigations specific for dysphagia are fiber optic direct laryngoscopy, which can view the laryngeal inlet and is useful for investigating patients of oropharyngeal dysphagia. Barium swallow, in which patient is given a radio-opaque contrast to drink, and the contrast is then X-rayed as it passes through the pharynx and esophagus. Video fluoroscopy is similar to barium swallow, but instead of still images, a video clip is made of the contrast passage into the stomach. It is considered a better study than barium swallow. Esophageal endoscopy. This is particularly useful in patients with esophageal dysphagia, in which a structural lesion is suspected. Esophageal manometry. In this test, a catheter is passed into the esophagus, which measures the pressure along the length of the esophagus. This is useful in patients in which a motility/propulsive cause of dysphagia is suspected. Management of dysphagia. Obviously, the specific management of dysphagia depends on the underlying disease. In general, here are the key points while managing a patient of dysphagia. Ensure adequate hydration and replenish any deficit electrolytes, such as sodium and potassium. Patients are usually malnourished and feeding can be started via nasogastric tube. If NG tube cannot be passed, then total parenteral nutrition via IV route might be needed. Patient might require feeding jejunostomy or gastrostomy for long-term feeding. Food consistency variation and diet modification might help some patient with dysphagia due to motility disorder, especially geriatric and stroke patients. Swallow positioning and pharyngo-esophageal exercises are also useful. Reduce aspiration risk by regular swallowing assessment, patient's positioning and airway protection measures. Oral hygiene with use of mouthwashes. Proton pump inhibitors, like omeprazole, might reduce the severity of discomfort of dysphagia. Antibiotics will reduce infection, especially in patients with increased risk of aspiration.